Right. So we are thinking about today AML MRD, and this is what I would like to cover. And there we have two techniques that can compete and outperform sometimes respective the patient the other. One is multiparameter flow cytometry, and the other is based on any kind of molecular assay. In that field we have several applications. So one we use since many years is called Quantitative Pcr, qPCR, or reverse transcriptase PCR, and with this we can follow up patients for one or more respective mutation. The sensitivity for the individual patient, and the gene has to be defined at diagnosis, ranges between 1 to 10,000 up to 1 to 1 million malignant cells in the benign background in remission. Remission, that means morphological remission or cytogenetic remission. So following this path now, using MRD in any kind of molecular assay, we first of all have to define the landscape of the respective leukemia cells of the patient at diagnosis. And doing this, we, over the last 15 to 20 years, experience a huge number of genes that were found out to be of importance in AML for pathobiology of the disease, for prognosis and prognostication, and even for specific targets for treatment. So today, the state of the art to define these respective genes that are giving all this information at diagnosis and open up the field for MRD in the respective patient, with or without allogeneic transplantation, is nearly based in all cases and should be based on a technique called next generation sequencing, NGS. And with this technique, we now have in our hands the option to investigate at diagnosis not one gene or 2 or 5, but 10 or 50 or 80 genes in one run. Even an exome or a genome would be possible, what is today not routine, it's research. But if we go at the time point of diagnosis, and let's say we investigate 80 genes of interest from which we know they play an important role for the diagnosis, for the classification according to WHO, what is in many cases now based on chromosomes or genes or fusion genes, then we, in one run, can multiplex a lot of patients for a lot of genes. And the turnaround time that is now able to achieve in a routine setting is below a week, even within 2 days. So that means that for some genes that may be very important right after the beginning, for the first hit of treatment, we can, let's say, wait 2 or 3 days before we have this information, and then according to this start with a targeted treatment approach. For example, in FLT3 ITD mutations or in the APL, this is one of the most important aspects where we pick up a specific fusion gene and start with a precision medicine drug. Now, if we now have these genes defined at diagnosis, then we need to define the respective assay for follow-up. And as I said before, there are several assays in parallel. That could be the best. For fusion genes, we normally rely on assays with qPCR with a sensitivity of 1 to 100,000. This can be done very quick, within 2 or 3 days. For specific genes with single point mutations, we need to look for other techniques. This could be Sanger sequencing, but this is not still state of the art because the sensitivity is ranging between 10 and 20%. This is never MRD. So we go for NGS-based techniques, reaching right now a sensitivity of 1 to 1,000 to 1 to 10,000. And with new assays and especially new software support, we will be better up to 1 to 1 million. By increasing the coverage for the respective mutations we are looking for. Another technique for MRD and AML is digital PCR. In digital PCR, we also follow the respective finding from the time point of diagnosis and just work like in the field of PCR by doubling this respective finding in very small little pellets to look for this mutation. With this technique, digital PCR, we also achieved now a sensitivity in 1 to 100,000 cells. That means we first of all described the diagnostic sample, the leukemia cells, by NGS and cytogenetics, pick up the respective changes in the chromosomes, in fusion genes or in genes, with any kind of point mutations, for example. And then knowing that, we define the MRD technique that is best for this patient, for this mutation we picked up at the diagnosis. And if we do this, we can very, very easily organize the further treatment, plus or minus allogeneic transplantation, stopping any kind of treatment, starting treatment again because the molecular relapse is increasing. And the time points we are used to do this is, let's say, every 2 or 3 months in complete morphological remission. And this is also what the ELN guidelines published in 2017 completely agree upon, using techniques like multiparameter flow cytometry or more and more molecular techniques, because we find out for more than 90% of the patients with AML a specific molecular marker at diagnosis. So we are increasing these techniques now for the time point of diagnosis and especially for MRD assays in the future.